Assalamualaikum and good day. We are from Group AA. We present a case on internal medicine. So patient is a male-female, 52 years old, with an I 30.49, which is hopeless. She was sent to PPOKM on 12th of April with chief complaint worsening SLB and epigastric pain. Patient was diagnosed with diabetic ketoacidosis secondary to community-acquired pneumonia. History presenting illness stated that she has cough for 1 week with sputum, fever on SLB and also vomiting. Past medical history shown that a patient has diabetes mellitus, but patient was not complying to oral hyperglycemic agent and also insulatide. Patient also has hypertension and dyslipidemia with no medication and has hypothyroidism with thyroid goiter. Father has type 2 diabetes. Patient is a retired clothes vendor. Then, moving on to patient progression. On 12th of April, objective evidence shows sign of DKA. Patient also had high temperature and WBC. Poor hydration, cough, and fever. On 13th of April, patient DKA symptom is improving, and patient has neck swelling likely sick of euthyroid, and patient will start antibiotic azithromycin and also azithromycin. And on 14th of April, patient have reduced hemoglobin, and DKA is improving, and metabolic acidosis also resolved. And on 15th of April, patient have positive fever and pneumonia anemia, also GI bleeding, and change antibiotic to IV tazocin. On 16th of April, a patient have low-grade fever, and perinatal treatment was in holds. And on 17th of April, patient was alert, mild, and paler. Next, on 18th of April, patient have dehydration, low BP, and also antibiotic was changed to isoflurane. And on 19th of April, patient was alert and hydration was bad, and patient was start metformin 1 grams. And on 20th of April, patient was hydration of patient was good, and 21st of April, patient have mild cough, and on 22nd of April, patient still coughing and have low grade fever, and she was kept nil by mark for OGDS. And on 23rd of April, we show patient have like lower log was inflamed, and yes. Next, this is the current medication list of patient. Okay.
Okay, moving on with the lab results interpretation. Firstly, we look at the blood glucose level. On admission, as seen here on the graph, the patient was on severe hyperglycemic state where the blood glucose was more than 11 millimole per liter. And as the patient is receiving management of DKA, the glucose level start to drop down and reach to normal values. However, on 18th and 22nd of April, the patient's blood glucose suddenly raised. Secondly, for the bicarbonate, on admission, patient's bicarbonate level is very low, below the normal value, indicating that the patient was on acidosis. As the patient was managed for her DKA, her bicarbonate level start to normalize, and by 14th of April, metabolic acidosis was starting to resolve. And from this graph, it is shown that the bicarbonate level has an increasing trend, showing that the patient has an improvement. Okay, next for the pH value, on the first day of admission, patient's blood pH level was below the normal range, which is 7.35 to 7.45, indicating that the patient was in acidosis state. With low level of bicarbonate, this showed that the patient was experiencing metabolic acidosis. And as patient was managed for DKA, the patient pH level was starting to increase and reach normal level by 14th of April. Next for ketone, the patient has a very high level of ketone, which is 6.2 in blood. This high level is due to insulin deficiency in the patient, where the body breaks down fatty acid and produce acidic ketones in the bodies. As the patient is managed for her DKA, patient's ketone level was showing a decreasing trend and starting to reach normal values. Okay, for the potassium level, on admission, the patient's serum potassium level was on the maximum normal value, which is 5. This elevated serum potassium concentration is due to the extracellular shift of potassium in acidic conditions. As patient was managed with insulin for her DKA, potassium levels start to drop, and hence patient was required to be supplemented with potassium. The patient's serum potassium level start to normalize after she was administered with potassium chloride with 15 ml. However, on 18th of April, her potassium serum level suddenly dropped to 2.6 millimole per liter. This is possibly due to cholestasis. Okay, for normocytic and normochromic anemia, we can look at hemoglobin and RBC count. From the beginning of the admission, patient's HB level and RBC count is low. This trend shows a decreasing trend from 12th to 15th of April. Thus, the patient was given blood transfusion and started on hematinic tablets. However, both HB level and RBC count start to increase from that date, but still did not reach normal values and keep decreasing. Lastly, for community-acquired pneumonia, first for the white blood cell count, on admission, the patient has high levels of WBC from the beginning, indicating that there is an infection. WBC level dropped on 13th of April, but started to increase until 16th of April. After 16th of April, the trend started to show a reduction of WBC level, showing there was an improvement in her management of infection. Lastly, for temperature, High body temperature in patient can reflect fever. Patient was admitted with high body temperature and was it started to reduce as patient's DKA was managed and antibiotic was started in the patient. On 15th of April, patient's temperature suddenly raised and patient was on fever, indicating that the infection still hasn't resolved.
Moving on to diagnosis and treatment, the first diagnosis for this patient is diabetic ketoacidosis, secondary to community-acquired pneumonia. The evidences to support this diagnosis include patient's hyperglycemic condition with blood glucose more than 11 millimole per liter, ketones more than 3 millimole per liter, pH less than 7.3, bicarbonate less than 15 millimole per liter, epigastric pain, vomiting, sign of dehydration, which include tachycardia and poor hydration, risk factor of infection, which is CAP, and patient's non-compliance with insulin therapy. For the treatment of DKA, firstly, patient should be managed on her fluid level. The patient could be first commenced with 0.9% of saline drip with the volume of 100 ml per kg of body weight. The fluid replacement alone could lower the blood glucose. However, the fluid intake should be modified based on the urinary output. The volume of fluid given could be reduced once the hyperglycemic was corrected. And secondly, the patient should be given insulin therapy. The fixed rate of IV insulin infusion could be commenced with the dosage of 50 units of short-acting human insulin and made up to 50 ml with 0.9% saline solution, thus to have a more rapid onset of action. Thirdly, there should be continuous monitoring on patient condition, which include hourly capillary blood glucose, vital signs, IR chart, improvement of clinical and biochemical parameters, and assess for complication of treatment, which include hypokalemia, induced arrhythmia, and fluid overload that lead to cerebral edema. Fourth treatment is the potassium replacement therapy. Potassium should be given when its level is lower than 5.5 millimole per liter, and the therapy should be started as soon as the adequate urine output is confirmed. The second diagnosis is the euthyroid syndrome (ESS). The evidences where the complaint of patient on the left side, neck swelling, mobile, decay is actually closely associated with ESS. Thus, for the management of ESS, the underlying disorder of decay should be well managed, especially on the controlling of the blood sugar. The third diagnosis is the CAP. It was shown by the evidences of unresolved infection, SOP, cough, fever, high LBBC count, presence of bacterial RLR consolidation, and comorbidities of patient. The first line treatment for CAP is the broad spectrum antibiotic, amoxicillin clavulanate plus azithromycin. Unless patient is allergic to penicillin, the first line antibiotic should be chosen before obtaining the CNS results.
Next, we go to the drug-related problem. The first DRP in this patient is the deep vein thrombosis prophylaxis. Patient has been given glycine that was started on 12 April but was withheld on 14 April, probably due to the decreasing hemoglobin level, as glycine can cause anemia. However, platelet count start to increase back. This is supported by the evidence of increasing trend of platelet count that recorded the highest on 22nd of April, which is 536. The goal of therapy of this DRP is to prevent the DVT in this patient, especially at high risk with abdominal obesity and hypertriglyceridemia. Also, patient is at high risk as diabetes has a propensity for hypermobility and DKA promotes a prothrombotic state. So for the management, we have to weigh the benefit of risk for giving the heparin to this patient, continue giving mechanical support such as DVT stocking, and we suggest to switch the heparin to tinzaparin. For the monitoring, we need to monitor the platelet count and looking out for the symptom of anemia. The next DRP is the unclear indication of the lactulose. As patient did not complain or showing any sign of symptom of constipation, but on 16 April, patient has received lactulose. So the goal of therapy is to prevent the unnecessary use of medication that might lead to unwanted side effect of lactulose, such as vomiting, diarrhea, that will further cause dehydration and affect electrolyte level, that will worsen patient hypokalemia conditions. So we need to review back the need of medication with the physician. So for monitoring, we need to monitor the bowel output side, monitor any sign of complaint of constipation, and monitor for the input output side. Next DRP is the inappropriate discontinuation of paracetamol tablet. PCM has only been given to patient on the admission day, which is 12 April, even though fever has not resolved. On the next day, the PCM is discontinued. So the goal of therapy on this DRP is we need to resolve the fever, thus PCM should be continued until fever has resolved. We need to monitor the patient temperature to know patient is still having fever or not. The last DRP is there is an abrupt stop of peridoppler with no proper justification. There is sudden discontinuation of this antihypertensive medication that will lead to hypertension. Patient is admitted with high blood pressure, but after the administration of phenolphthalein, her BP is controlled. That suggests the BP is controlled due to the administration of phenolphthalein. So the goal of therapy is we need to adjust patient in achieving the therapeutic target, which is 130 over 80 mFHg. So for the management, we need to discuss back with the doctor on the possible reason for stopping the phenolphthalein and suggest the most appropriate antihypertensive medication according to patient profile. So we need to monitor the blood pressure frequently. Next.
Right, moving on is the PCI. So the first PCI is actually inadequate management of first the rate of infusion, second the continuous fluid replacement. So as you can see, when the patient was initially admitted, the rate of IV infusion of the insulin is supposed to be 8.3 unit per hour. However, patient was only given 6 unit per hour. So the goal of therapy is to maintain serum potassium in normal range and also ketone, bicarbonate and blood glucose or within range. The management is that we should give calculation of dose should be done precisely based on the patient's weight, and patients should receive 8 unit per hour for a quicker decrease in glucose and also ketone level. So moving on is the continuous fluid replacement, where it stated that blood glucose falls below 14 millimole per liter, there should be a switch to 5% dextrose and 0.45 normal saline. However, in this patient, fluid with dextrose is not given. So that might lead to a problem, which is further ketosis that may occur, plus the ketone is not documented on the 13th of April. So we should actually monitor the blood glucose level, ketone level, and also ABG values of this patient. So next is the elevated liver function test, where we can see there is a raised ALT and ALP. In this patient might indicate the patient is having injury or impairment in the liver. So this is possibly due to the glycogenic hepatopathy, which is a complication due to uncontrolled diabetes. So besides, we also suspect that there are medications that patient is on is actually affecting the hepatic profile, which is as listed. So management is that we should rule out the reasons of abnormal elevated LFT value by referral to physician to identify the underlying issue. And also the goal is to normalize the abnormal LFT value. So we should constantly monitor the liver profile, which is the serum transaminases. Besides, there is a PCI, which includes the IO chart, incomplete IO chart. So with that being said, we are unable to identify the hydration status of the patient to further evaluate the appropriateness of the management. So to ensure the fair hydration of patient and to identify the dehydration earlier and to manage the patient with continuous fluid replacement, we should always monitor the patient hydration status with IO chart recorded daily. So moving on, next is the inappropriate administration choice of antibiotic for CAP. So patient is started on ceftriaxone plus azithromycin, which is not the first line treatment for CAP. Then along the way, patient was changed to antibiotic tazocin, which is also not recommended in the guideline to treat CAP. Hence, we can see that the infection is still unresolved in this patient. So the main goal of therapy here is to eradicate the patient the causative organism that is causing the infection and to resolve the symptoms of infection. So the preferred treatment here is amoxicillin clavulanate plus azithromycin. So we should monitor the chest X-ray and also vital signs like WBC, temperature, and CRP. Next is inadequate management of anemia, where there is a constant low hemoglobin RBC count, where patient was diagnosed with normocytic and normochromic anemia. However, despite the blood transfusion, hematinic and folic acid being given to this patient, there is no improvement, and hence what we should do is actually to rule out the underlying bleeding or anemia by using endoscopy, and also to resolve this anemia by appropriate management of infection or bleeding. So with that, the goal of therapy is to increase the patient red blood cell count and also the hemoglobin level and to resolve the anemia. So what we can do is the constant monitoring of the fluid blood count. All right, next is the adherence issue, where patient is not compliant to her anti-diabetic medication. So this is a precipitating factor to DKA as well. So we can see that the patient was admitted to the hospital with an uncontrolled diabetes mellitus. So what we can do is to identify what is the barrier that causing the patient not adhering to the medication, and giving her proper education, explain to her the importance of better glycemic control in helping her to achieving the therapeutic target and also to improve her adherence. So with that, we should monitor the blood glucose level, HbA1c level, and also patient's perception and knowledge. Next, patient has the possibility of not taking her medication for hypertension and dyslipidemia. So with that being said, there is an unclear medication history, so we are unable to identify whether the patient is taking the medication or not, or whether the patient is compliant. So what we should do is to rule out the diagnosis of hypertension and dyslipidemia and to ensure that the patient is adhering. So when the patient is well and conscious, we should take a proper medical and medication history and do a profile test on lipid profile of the patient to set the baseline. And
okay, next moving on to the monitoring plan for therapy of DKA. Monitor the level of venous pH, bicarbonate, potassium, black ketone, blood glucose, and input output chart. And for safety, monitor the sign of hypokalemia, dehydration, and hyperglycemia. And then for CAP therapy, monitor for sign symptom of eradication of infection such as temperature, WBC count, CRP level, and culture and sensitivity test. And for safety, monitor any sign of hypersensitivity reaction after starting antibiotic such as anaphylaxis and sclerosis, and also monitor the side effect of the antibiotic such as diarrhea, loose stool, nausea, and vomiting. For hypertension therapy, for efficacy, monitor the blood pressure levels, and it should be lower than the target level, which is 120/80. And for safety, monitor the side effect of dry cough, swelling of leg or ankle, headache, and also rhinitis, and monitor also symptoms of hypertension such as dizziness and fainting. And for dyslipidemia therapy, for efficacy, monitor patient lipid profile such as total cholesterol, HDL, LDL, and triglyceride. And for safety, monitor serum transaminase, and also monitor the side effect of statin such as abdominal pain or headache, and also myopathy. And next, for therapy of hypokalemia, for efficacy, monitor patient electrolyte levels, which is potassium, and also for safety, monitor any cardiac function, also observe any sign of extravasation at other side, and also monitor side effects such as nausea, vomiting, and also diarrhea. And for anemia, for efficacy, monitor the patient for blood count to see the improvement of RBC count and also hemoglobin levels. And also for safety, monitor for common side effect for ferrous sulfate, which is constipation. So here are references. That's all from us. Thank you.
thank you.